How often have you seen a person, or maybe an organization, do something where it seems like they're doing it almost just for the sake of it?
Are you sure that's absolutely necessary?
Oh, it's not really necessary.
Oh, I'm sure that's not necessary.
Are you sure this is absolutely necessary?
Sir, is that actually necessary?
That's not necessary.
Maybe for the optics, or maybe out of desperation, rather than actually achieving any impact. Our brains are inherently lazy and rely on automatic processes and mental shortcuts, otherwise known as heuristics, to improve efficiency in decision-making, while some cognitive phenomenon push us towards inaction, for example, inertia, default bias, or status quo bias. In certain circumstances, we can be more programmed towards non-rational activity, even despite there being no genuine utility. This tendency towards action, in order to gain a sense of control over a situation or to eliminate a problem, is known as action bias. It's particularly likely to occur when others expect us to take action, i.e. social norms, or amongst certain individuals, for example, people who are more overconfident, or in cases where there may be regret from prior inaction. Whilst action can lead to reward, this default impulse also occurs when evidence doesn't support any benefit, and action bias can therefore be a form of non-rational behavior. Another term for our tendency to favor action, even if it leads to no benefit, is commission bias. A common example to highlight action bias is shown in football. During penalty kicks, a goalkeeper is most likely to prevent a goal by staying grounded in the middle. However, goalkeepers will often feel compelled to leap to one side or the other, pressured by the expectation of onlooking crowds. Or something many of us might relate to is the way, during traffic, drivers might exit the high road and try to take shortcuts through narrow side streets, even though it might ultimately take longer, rather than just waiting patiently through the traffic on the high road. And action bias can be seen at every level in healthcare, from patient behaviors, clinician choices, as high up as the decisions made by policymakers and politicians who need to demonstrate impact to their constituents. Even in ancient Greece, Aristotle observed that in the arena of human life, the honors and rewards fall to those who show their qualities in action. Others cannot always see our efforts, which is why individuals might feel compelled to take extra steps in order to signal an association with positive rewards. We've talked in previous videos about the high proportion of ineffective or even harmful practices in healthcare. As described in that video, through cognitive illusions, ineffective healthcare interventions can be incorrectly linked to an improvement in symptoms, and such erroneous belief reinforcement perpetuates those practices. Studies have demonstrated the propensity of clinicians to overact. Numerous factors likely contribute to this. Overconfidence is thought to be prevalent in clinical practice, and clinicians across many specialties commonly overestimate diagnostic probabilities as well as the benefits of their interventions by a very large margin. Studies also cite circumstantial pressures such as patient expectations, as well as clinicians' general desire to do something for their patients, being unaware certain interventions may be ineffective. Other factors include defensive medicine due to litigation risk, or clinical guidelines which set a very low bar for intervention. As a result, clinicians can develop a high sensitivity to low probability events, becoming intolerant of even the lowest near zero risks related to inaction. Action bias and healthcare overuse can also influence how patients will behave in future instances of the same illness. For example, let's consider antibiotics. We know there is ubiquitous excessive antibiotic use for self-limiting respiratory tract or throat infections, whether viral or bacterial, that will usually have a natural history of resolving without intervention. Using antibiotics too much when they're not needed can have several harms, from gastrointestinal side effects, disruption of an individual's microbiome, to development of the very serious problem of antibiotic resistance. But studies show people have an action bias in their preferences for antibiotics, even despite education about the lack of benefit and potential harms. And when doctors take action, for example, to prescribe antibiotics for a sore throat, this increases future consultation rates. Whilst the illness likely just gets better by itself, about 90% of patients will then think the antibiotics are effective, and that they will need them again for such an ailment. However, when antibiotics are not issued or given as a delayed prescription, it helps individuals recognize that medical treatment is not always needed, and around a quarter of these patients will subsequently aim to self-manage their illness rather than seeking unnecessary treatment in the future. Professor Tom Marshall coined the term the number needed to not treat, highlighting how many times a doctor needs to refrain from deploying an ineffective healthcare practice to positively influence one patient's future health-seeking behaviors and empower someone to effectively self-care for common self-resolving ailments. In this scenario, 3 cases of antibiotic restraint results in one individual recognizing antibiotics are not that effective, and 4 cases of antibiotic restraint results in one person not even consulting again and instead self-managing such a minor ailment. There are endless examples highlighting that less is often more in medicine. For example, studies in the US show that patients with heart attacks or heart failure have better outcomes if they're admitted during national cardiology conferences, when many cardiologists are away from hospitals. In fact, the improvement seen is even greater than that achieved from many of our most effective cardiovascular treatments. It's theorized the absence of certain doctors results in some patients being managed more conservatively during these periods, with lower use of medical interventions which are less beneficial and even potentially harmful to these individuals. Another highly evidenced area of low-value healthcare overuse is with medical diagnostics, with evidence that increasing use of tests will often lead to worse patient outcomes rather than any benefit through misinterpretation of results, false positives, or clinically irrelevant incidental findings, causing stress impacting on many domains of an individual's life and leading to non-beneficial further healthcare utilization. Action bias will often influence patient decisions, sometimes with negative consequences. For example, few people can imagine standing by and doing nothing after being diagnosed with cancer. In this study, people would pursue treatment, even if doing so would actually increase their chance of death. Most of us can agree that a key tenet of healthcare is to enable the most people to live with the highest quality of life for the longest time possible. And whilst it's intuitive that doing more may be better, it is very likely, particularly in many developed settings, that we can reach not only a plateau, but a point of negative returns through excessive medical interventions, with negative impact on individuals and our healthcare systems. Dr. Donabedian, a key innovator in healthcare quality improvement in the 20th century, coined the Donabedian curve, which highlights not only the diminishing returns from increasing healthcare activities, but also the rising harms. When certain medical activities expand beyond a point of optimality, there can actually be an overall reduction in net benefit. With all health conditions, whether there is diagnostic or treatment confidence, or even when there is uncertainty, bear in mind, diagnostic uncertainty is incredibly common throughout healthcare. For example, in at least a third of primary care consultations. As a doctor and a patient, it's worth questioning 3 themes. 1. What might happen if I did nothing? Also described as the test of time.
Is this necessary?
2. Is it possible that the natural history of these symptoms might include self-resolution without any intervention?
You might get better.
And 3. If I do undergo further testing or start a treatment, exactly how much positive impact would this likely have on my recovery? And what are the costs and trade-offs of taking such action?
What difference does that make?
What difference does it make? What difference does it make? Difference doesn't make how much it is.
How much this cost?
How much is that going to cost?
How much would it cost?
Because further investigations or treatments can all have adverse consequences, as well as opportunity costs, not just in money, but in time, energy, and resource. And many treatments are much less effective than we often assume. In the example discussed earlier, for the overwhelming majority of respiratory tract infections in the community, antibiotics have no significant impact above placebo. This Cochrane review showed that all they did on average was speed up recovery by about half a day. The antidote of action bias is described by the Chinese principle of Wu Wei, roughly translated as non-doing, an attempt to harness the power of the natural history of events. Think of it as strategic passivity, achieving the most through the least exertion, or effortless action. In healthcare, at a time when we have tremendous technologies available at our immediate disposal, often the things we refrain from doing may be as valuable as the things we do.
Show some restraint.